Good afternoon, everybody. It's Friday, the 23rd of July. You're here at Lunch and Learn. We're going to keep everybody muted for the time being. Today we have a guest speaker, Jack Ginsberg. Jack's been with us several times before and does a great presentation. And today he's going to be talking about co-regulation of heart rate variability by resonance frequency breathing and pro-social emotions. I'm not going to give you any more background on Jack. We want to maximize his time and give time for questions. So Jack, thanks so much. You're a busy guy. We're so happy to have you back here, and it is all yours.
Oh, thank you so much, Rob. Two of my best buddies in the world are Richard Suter and Rob Longo, and I hope and look forward to having more interactions with them. There we go. So there's those two guys right there, and a little plug for NewMind, and I thank you so much for bringing me on board for this Lunch and Learn again. There's a little bit about me, contact information. If you would like to follow up, I'll be happy to do what I can if there are questions afterwards. So the usual disclaimers and disclosures, there's nothing here different from what I've done in the past. So let's start then with the basics of HRV. And what I do want to do is try to find a common ground between HRVB and neurofeedback. But truly my expertise, such as it is in heart rate variability. So let's take a look at the foundation of heart rate variability. Number one, heart rate variability is calculated from interbeat intervals. That's the same thing as pulses. Resonance frequency breathing is around 0.1 hertz, which is 6 breaths per minute for most people. Phase synchronization of respiration. Oh dear, my dog is barking. I don't know how to mute that. We'll just
Not
press
on.
Then.
I can hear you
okay,
fine.
Yeah, that's good. I'll try to keep her out.
You're good. You're good.
Okay. Phase synchronization of respiration, heart rate, blood pressure, and vasomotor tone amplifies heart rate variability. The two closed loop barrel reflex system that Lair has promoted for many years comprises these four systems: respiration, heart rate, blood pressure, and vasomotor tone. Polyvagal informed therapy, which is coming on now, is a very exciting and well-grounded approach to top-down psychotherapy based on this idea of vagal control of heart rate, emphasizes the role of safety and pro-social emotions in well-being. HRV increases when RSA, or respiratory sinus arrhythmia, oscillations increase, meaning that the interbeat intervals that occur over the course of a respiration cycle, the max to min is maximized. These heart rate oscillations, also called RSA, are increased by heart rate variability biofeedback, which is slow-paced breathing. Resonance frequency breathing maximally increases RSA and HRV, and that's due to the phase lock synchronization of those physiological systems we just talked about. HRVB trains resonance frequency breathing and increased RSA, that is heart rate oscillations or heart rate variability, through slow-paced breathing. Amplification of RSA and HRV by this biofeedback results from phase locking of heart rate with baroreceptor reflex that maintains blood pressure homeostasis and vasomotor tone. So some of this is redundant, but it's worth repeating. And lastly, then, for our basics, heart rate variability biofeedback, resonance frequency breathing or slow-paced breathing, and increased heart rate variability all improve well-being without or with intentional top-down therapies. We'll talk about top-down therapies a bit more, but just to give you a list of these top-down therapies, they include polyvagal informed therapy, emotion regulation, integrative pathways, compassion meditation therapy, mindfulness, acceptance and commitment, emotional awareness and expression therapy, positive psychology, awe therapy, rational emotive therapy. These are all therapies that pertain to thoughts and emotions and are intentionally generated. These top-down therapies improve well-being without or with the intentional heart rate variability or resonance frequency breathing or slow-paced breathing, meaning that clearly there's bidirectional influences between the thoughts and emotions and the cardiac function in terms of IBIs, baroreceptors, and the phase locking. Heart rate variability is significantly and positively correlated with cardiac vagal afferent neurotransmission. So this begins to get us into the overlap that I want to explore a little bit more between effects of the heart rate variability biofeedback and neurofeedback. Increased heart rate oscillations increase activity in brain regions controlling emotion regulation. So we do have a big bowl of spaghetti here where things are connected. We have thoughts and emotions influencing heart rate variability affecting neural structures that control emotion regulation affecting well-being, and so on. So what are these top-down and bottom-up therapies? Top-down mechanisms. This is a wonderful article, and I highly recommend it for all of you who are interested in questions like this and the whole idea of mind-body. Top-down mechanisms are those initiated via mental processing at the level of the cerebral cortex. In the case of clinical hypnosis, imagery, or meditation, for example, we are primarily referring to conscious and intentional mental activities, although unconscious neural processes are also thought to be involved. In contrast, bottom-up mechanisms are initiated by stimulation of various somatovisceral and chemosensory receptors that influence central neural processing and mental activities via ascending pathways from the periphery to the brainstem and cerebral cortex. However, we also stress that this taxonomy is an oversimplification and that all mind-body therapies actually involve a combination of both top-down and bottom-up mechanisms. So this idea here that there are somato and visceral, for example, cardiac afferent neurotransmission would be a visceral, a bottom-up type of stimulation. So just to clarify, it's a simplification, it's important. Bottom up does not mean anatomically below, transversely, or caudal inferior relative to a cranial position in an upright animal. So below the heart, because the heart is below the brain, doesn't make it a bottom up type of process. Cardiac vagal afference is not bottom up because the heart is below the brainstem. Vagal afference does have some bottom up characteristics, because the R peak of the ECG signal and the baroreceptor reflex both are stimulation. Those are our visceral or internal receptor type of stimulations that trigger central nervous system activity. However, vagal afference also results from top-down influences. So when we do HRVB or resonance frequency breathing, these are intentional and top-down processes. So there was some recent news, very exciting, and it gave me some thought about this top-down and bottom-up. You might have seen it. It's just a week old now. Study marks important step towards restoring natural communication for people who can't talk. It was in several of the newspapers and science reports. In a person with anarthria and spastic quadriparesis caused by a brainstem stroke 16 years ago, words and sentences were decoded directly from cortical activity during attempted speech with the use of deep learning models and a natural language model. The study also showed that cerebral cortex can generate electrical representations of speech and language even after 16 years of paralytic anarthria. Well, now you'd think if these are complex EEG signals that are being recorded from the cortex, gosh, that you'd think, well, maybe that is bottom up, because it seems like it's some kind of stimulation. But in fact, I think really this would be an example of top down, even though it's not a it's not a coherent set of thoughts and emotions, but it would be top down nonetheless, because they are being intentionally produced. The individual was, you might say, thinking of words which he had learned already to communicate with on a soundboard, and by intentionally producing a pattern of cortical electrical activity, that could then be decoded with a relatively high accuracy. So just to give you an example then of how it is that top down and bottom up can get a little bit sticky. Heart rate variability biofeedback increases a person's access to emotion regulation. That's through the baroreceptor reflex and improves stress responding and resilience. Vagal afference to brainstem and cortex activate emotion regulation network. Emotion regulation is the experience of adaptive, positive, for example, prosocial, and negative emotions with the goal of producing successful social interaction and feelings of safety. So this idea of emotional regulation is not the same as happy thoughts. It is adaptive emotions with respect to both environmental and social stimuli. Central to improved clinical outcomes of chronic disorders, including pain, PTSD, anxiety, and depression. So emotion regulation is really a very potent construct for psychologists and anyone in the helping professions because it's a way to create a field of behavior on the part of the people coming to us for help. By improving emotion regulation, we can really affect some clinical improvements. This presentation today considers the co-regulatory role of the effects of resonance frequency breathing on emotion regulation enhancement with social engagement and safety signals. So while it supports the polyvagal theory, it also will point the way to begin a unification of heart rate variability and neurofeedback. So this emotion regulation has some characteristics that are, I would say, pretty well accepted and pretty widespread in the clinical literature. It is top-down, it's adaptive, it's regulated for function, it's flexible, stable, and individual to some degree. It's produced by interaction between biological constraints and social environment. It may become dysregulated and maladaptive. The adaptive emotion regulation is mistakenly equated with minimization of negative emotion. So therefore, it includes both positive, including prosocial, and negative emotions. It also uses regulation or reduction of emotional intensity. It relies on genuine experience and expression and goal of safety and social interactions. So these ideas have been kicking around for a while. It's not exactly earth-shattering, but it may be something that needs a little bit more emphasis than has been given in the past. Fred Schaefer, an outstanding colleague in the field, reported or presented something like this back in 2013. You can see right here the emotional self-regulation is a part of a biofeedback training session that includes resonance frequency and mindfulness. So while it's not new, it certainly is important and should be emphasized. The overarching purpose of heart rate variability biofeedback training is to improve the client's ability to self-regulate and enhance quality of life and performance. Successful HRVB training integrates mindfulness, self-regulation of emotion, and resonance frequency breathing. Okay, so we got a pretty good picture there. Well, again, this whole idea of going back even further into our friends at HeartMath who have pioneered much of the heart rate variability and biofeedback the field. In these articles that are produced by their staff, and Roland McCready, of course, deserves mention here. As he writes, heart rate variability studies have revealed the importance of heart rhythm patterns which reflect emotional states. Important findings were that negative emotions such as anger and anxiety, as well as positive emotions such as peace and happiness, tend to have characteristic HRV signature patterns. So one thing we want to begin to do right here is expand this idea of positive emotions so that we can include within emotion regulation both positive and negative. But as he's also written in some earlier work and to some degree has repeated many times, there's a bidirectional system whereby the brain sends information to the body through efferent neural networks, and the body communicates with brain centers via sympathetic and vagal afference inputs to the thalamus, amygdala, and other subcortical structures. So let me emphasize that we are concerned here and interested in both efferent, which is emanating from central nervous system, in large part or overlaps quite a lot with this idea of top-down, and afferent inputs to the central nervous system. And so afferent to some degree is mostly bottom up, as long as it's at the level of receptors. So we have efferent and afferent communication, and that's the bidirectionality of mind-body. Self-induced positive emotions can shift psychophysiological systems into a more globally coherent and harmonious order associated with improved self-regulation, performance, and overall health. So we need a bidirectional model. So we have to have central nervous system communicating with the bottom-up signals from, in this case, cardiac autonomic signals. So at one point early on, this idea of regenerative feelings such as appreciation care, this was all lumped under the idea of positive emotions, and it's something that needs to be expanded now into emotion regulation. So let's take a minute, a little side trip here, and talk about the polyvagal theory. This is just simply a snapshot of some of the central features that there are three different stages of development represented in evolutionary development of the complex of autonomic function that includes an unmyelinated vagus and then a withdrawal of sympathetic, withdrawal of vagal inputs to create a sympathetic dominant system. And lastly, the highest or more recent level for mammals is the myelinated vagus, which allows us to have social affiliation and calming. Without going too deeply into that here, the polyvagal theory has stood up to criticisms that are coming along now, and there's quite a bit more to this theory. So this snapshot only gives you just a quick overview of it. And I don't want to go into too deeply into that, but what it has led to is this idea of the social engagement system. So the social engagement system, which is under regulation of the vagal complex, it's a term for this phylogenetically dependent polyvagal hierarchy from recent to primitive, where the ventral vagal activity that regulates facial expression and affiliative behavior emerges in mammals and especially well developed in primates. The sympathetic adrenal system is shared with vertebrates for mobilization, and an inhibitory immobilizing dorsal vagal, that's the unmyelinated, that is shared with primitive vertebrates such as reptiles, for example. So the point here that we want to make is that the vagus complex can be understood to be critical for producing affiliative behavior, social engagements, cooperative behavior, things that sound a lot like emotion regulation and kind of begin to put us on the track towards how it is we can enhance and strengthen our emotion regulation, and what the goal of that strengthening is to increase and improve our social engagements and sense of safety. So Sue Carter, of course, is very famous for her work on oxytocin. It's based on the same ideas, the same structures, and the same pathways. Non-selective social engagement leading to social reward, bonds and love, sense of safety, calm, and avoidance is, might say the opposite, or is the other type of activity that is also under regulation of the whole vagal and is incorporated within the vagal theory. So what this has led to very recently now is an institute called the Polyvagal Institute, which is dedicated to developing this polyvagal informed therapy. This is the idea of co-regulation. And in a sense, this is accomplishes the first part of the talk, which is that it's co-regulation then between a therapist and a client, or a helping professional and someone who's coming for help. It's that co-regulation and the production of affiliation and safety within the therapeutic environment. That's what co-regulation refers to. So how do we do this pro-social thing? What does that mean? Well, pro-social thoughts and feelings include sense of responsibility and connectedness. Words like affiliation, friendship, helping, empathetic or empathic, compassionate, caring, love are all used to describe pro-social emotions. So you can see here we've staked out a position that's distant from the earlier ideas of positive emotions, which are more or less limited to gratitude or appreciation. And we can expand this now into a wider framework, adaptive framework, that can be created with top-down therapies. So is caring for the environment pro-social, for example? Well, caring for the environment is pro-social if it's a part of caring for other people. Is the pursuit of happiness pro-social? Well, pursuit of happiness is pro-social if caring for people is a part of the happiness that's being pursued. If not, then a pursuit of happiness is seemingly not pro-social. So that's what polyvagal informed therapy is trying to do. It's trying to instill safety in the patient. It's trying to create accessibility to the feelings, thoughts, and behaviors that are pro-social towards the social and physical environment. And attentiveness to threat in the social and physical environment through neuroception is one of the key and unique aspects of the polyvagal theory. And as I indicated, there are a number of publications now, books, articles, and so on pertaining to this. So in a nutshell then, the pro-social emotions are central at the very heart, no pun intended, but positive emotions, which are included with negative emotions under the entire umbrella of emotion regulation. Now, cardiac vagal afference. We'll start moving a little bit more towards the central nervous system aspect of this. Cardiac vagal afference is significantly and positively correlated with heart rate variability. Vagal afference is bottom-up information from heart to the CNS. It includes the R peak of the PQRST-HR complex as a stimulus. It can be recorded as prefrontal cortex delta oscillations, as well as cortical event-related potentials. It is influenced by top-down responding and control, and it's involved in modulating mood and affect, including anxiety, depression, and fear. So we can think of this then as a cycle, which can be entered through resonance frequency breathing, which leads to effects on emotion regulation. And we can also think of it as a top-down process that begins with emotion regulation and leads to influences on heart rate variability and cardiac autonomic features. So this idea then of cardiac vagal afference is certainly not new. Again, McCready has been pushing this for a long time, and he famously repeats a set of observations. Veldin and Volk demonstrated cognitive performance fluctuated at a rhythm around 10 hertz throughout the cardiac cycle. They showed that the modulation of cortical function resulted from ascending cardiovascular inputs on neurons in thalamus, which globally synchronizes cortical activity. There has since been a growing body of research indicating that afferent information processed by intrinsic cardiac nervous system can influence activity in frontocortical and motor cortex, affecting psychological factors such as attention level, motivation, perceptual sensitivity, and emotional processing. So while there are a number of references here, this is, and it is a foundation here. There's much more that needs to be said and more detail to move us forward. So more recent studies then, two studies that Professor Gevirtz has been involved in that have looked at cortical response to heart rate variability or to cardiac function. The first one, investigation of vagal afferent functioning using the heartbeat event-related potential, found that the study validated that the evoked response potential amplitude could only be observed in individuals in the biofeedback condition, as well as the HERP amplitudes during session baseline distraction segments increased with more HRV biofeedback. So we're beginning to perceive a direct relationship now, a quantifiable relationship between a heart rate variability, which is based on interbeat intervals, and cortical potentials. And in the second study, HRV, which is utilizing heartbeat evoked potentials to identify cardiac regulation of vagal afference during emotion and resonance breathing. HRV influences the afferent input to the brain during the experience of emotion, as well as during resonant breathing. The low frequency domain of the heart rate appears to be particularly connected to the amplitude of the evoked potentials. And right more or less almost smack dab in the middle of the low frequency range is the resonance frequency, or the 0.1 hertz is very much mid-range of the low frequency. So it may well be that really what this is referring to here is the resonance breathing is where the afferent input is particularly connected to amplitude of the evoked potentials. Well, there's more and very exciting relatively recent research that was presented at the AAPB virtual conference last fall. Work done by Mara Mather and also collaborating with Julian Thayer about heart rate variability affecting emotion regulation brain networks. And in this very carefully done and extremely thorough, well-controlled experiment, manipulation of HRV, but not emotions, was shown to influence the emotion regulation network at an fMRI level. Inducing high amplitude heart rate oscillations via slow-paced breathing enhanced emotion regulation neural network function. By manipulating HR oscillations, Mather demonstrated that an increase in activation occurred in brain regions associated with emotional regulation after heart rate oscillations increased, but activation in the same regions did not occur after oscillations decreased. Furthermore, a behavioral measure of emotion regulation while viewing pictures increased in the high oscillation group, but not in the low oscillation group. So this is really a kind of a way of saying that resonance frequency breathing will produce effects on emotion regulation, except that it was not done through controlling resonance frequency breathing per se. There was a protocol here which produced a tachygram that looks very much like a heart rate, the sine wave of a heart rate variability biofeedback session. And there's your high and your low oscillation subgroup. And the changes in functional connectivity were striking, as indicated by by fMRI activations. And it was localized to regions that are known to be associated with the emotion regulation. The left amygdala and medial prefrontal cortex functional connectivity increased functional connectivity across resting state. That's the default mode network involved in emotion and interoception, and increased ability to diminish on demand brain activities associated with feelings. In other words, regulate your emotions. Well, earlier, Thayer had already presented or proposed a complex pathway, neural pathways, neural circuitry, whereby heart rate could be controlled from prefrontal cortex. And that's a major insertion into a simple pathway that expands this idea that the vagus is uniquely somehow controlling of heart rate. And so this is all about bringing in a broader, moving from the brainstem and those circuits like the nucleus tractus solitarius that are directly connected to the vagus, moving from that area, that relatively circumscribed region of the brain, into a much broader and bringing in cerebral cortex as well as intentional control of emotions, And so we're widening our whole concept here of autonomic control and looking at the bidirectionality now, both connectivity across cerebral cortical structures, as well as inputs and bidirectional interactions with the peripheral, in particular the heart. But most recently then, Thayer again points us in the direction of frontocortical control that is directly connected to vagus. And this is an extremely significant, in my opinion, this is an extremely significant bit of evidence here. Using logistic regression models, cardiac-related EEG predicted trial-by-trial occurrence of long and short from delta power reduction over prefrontal and frontocentral areas. So we're able to direct or to connect prefrontal activity with IBIs. Delta power oscillations preceding the R wave from the heart, of course, increase the probability of a long IBI to occur as compared to a short one. Reduced prefrontal delta power preceding the R wave was correlated to higher cardiac vagal control as reflected by high frequency power of HRV. A reduction in EEG oscillations in low frequency range over prefrontal areas preceding and time locked to the following heartbeat was predictive of increased beat-to-beat vagal control of the heart. Well, there's more to it than that, of course. The well-known prefrontal cortex alpha asymmetry and negative affect imbalances in PFC activation are associated with affective symptoms, as well as inadequate responses to stress. Shifts in frontal hemispheric EEG dominance during top-down cognitive interventions, such as meditation imagery and hypnosis. And you can see here I'm returning back to Taylor. It's a magnificent article, in my opinion. And that shifts in this hemispheric EEG dominance, this asymmetry, during top-down therapies do reflect effects of central nervous system, not only on the peripheral autonomic outputs, but also on mood and well-being. So these interventions that decrease right side PFC activation, in other words, reduce the asymmetry with major depression, can be produced by neurofeedback as well as psychotherapy, as well as massage therapy, at least in children. So we get this idea now that the central nervous system and the cortex is really another key to affecting mood and affect. Now, this is not new. This is not a high-level news for you, but for the neurofeedback guys. But what's important about it is that it now incorporates this direct link with autonomic control of the heart. And so that's where we can begin to see a bridge between functions that are going on with respect to cerebral EEG, as well as through heart rate variability and resonance frequency breathing effects on baroreceptor and vagal afference. And lastly here, the last bit of evidence I want to throw out, professional soccer players and elite athletes were given training in either HRVB or neurofeedback alpha power increase. Results showed that both groups showed significant increases in both HRV indices and alpha power. So it's two different pathways that both lead to the same two different outcomes, suggesting that, quote, a coaching program combined with either HRV or EEG alpha power feedback may increase HRV and alpha power and lead to better performance-related outcomes and stress reduction. So I've attempted to model this here, showing the bidirectionality and some of the key structures involved here. And I want to emphasize that your vagal afference here can go through default mode network and PFC and find a route to the brainstem vagus, which in turn has a pathway to emotion regulation as well as top-down processes. And we can connect cortical ERPs and alpha power, although this link here pretty much goes through the delta oscillations at this point, The cortical ERPs as yet are not really coherently related to the outcomes of emotional regulation or, for that matter, on autonomic control of the heart. So in conclusion then, cardiac afference to vagus affects baroreceptor reflex, and to cortex affects default mode network and emotion regulation via PFC. PFC delta oscillation signals influence vagal control of HRV. PFC alpha asymmetry is associated with negative affect. Cortical reorganization occurs due to mind-body or top-down therapies that appear to involve reduction in PFC asymmetry. HRVB increases PFC alpha power, and alpha power NFB increases HRV. Neurofeedback effects on prefrontal cortex, delta oscillations to vagus, right side alpha asymmetry, and alpha power offers a promising entry point into unification of effects of neurofeedback with heart rate variability biofeedback as top-down therapeutic processes affecting both vagal activity and negative affect. All right. Looks like I got through it in pretty
Yeah,
good time.
great
Yeah.
timing. So we have about 15 minutes for questions. So what we'll do right now is Richard will slowly begin to unmute people. It'll take him maybe a minute or two. He has to do it one by one with this software. So in the meantime, great stuff, Jack. This is really interesting, and I think for all of us that are working, with people in general, and looking at the benefits of HRV, this really opens up some interesting avenues for understanding how people work and helping them relax and all that, and then the intertwining of it with neurofeedback is really incredible. So as we were talking about earlier, blending these two together really makes a dynamic way of working with folks.
Yeah,
Well, it's beginning. I think it's already happening. There certainly are instances where therapists are able to work with both. But
Yeah,
what I'm seeing is that we're this is still a frontier right now. And so it's something that is to be developed and broadened and widened. And we want a vernacular, we want a pathway or mechanism. We want to understand how and why it is. If we have different pathways to the same outcome, then there's no sense in not combining those pathways and enhancing both.
absolutely. Richard, you were going to say something.
yeah, I was going to say that the NewMind protocols, since we started running them over a decade, have been focused a lot on asymmetry because of its impact on mood. We know, and the whole NewMind system is built around asymmetry and anxiety and depression, and managing that asymmetry, and the Polyvagal Theory and the concept of ascending vagal pathways. And we have promoted heart rate variability as something that should be used with our neurofeedback for that same decade. So this is really significant for NewMind practitioners, because this is the heart of what most of us do, is combining heart rate variability with asymmetry training. So this Jack moving in this direction and formalizing the language and showing the data is just terrific support for the direction that we've been going in, and I think was ultimately something that had to come out of the research that we've been seeing at AAPB for the last couple of decades. So I just am wonderful that Jack is right on this and really helping to push this forward.
Well, Richard, this is talk a little bit more about what your protocol is, your integrated protocol, how it works, what effects you see, what obstacles, if any, compare and contrast how it is that NewMind goes about using an approach that looks at frontal asymmetry and heart rate variability. I mean, you've got it going in practice. So this, I think, would be very enlightening to HRV people who may at least be dimly aware of it, but flesh it out a little bit for us.
Well, yeah, the most of our practitioners we encourage them to use heart rate variability, and they'll use it for 10 or 15 minutes prior to the session, enhancing coherence, because that enhances the ability to do the asymmetry training. So all our protocols are homotopic. They're homologous. They're, because the networks are F3, F4, C3, C4, P3, P4. So most of the protocols are training and balancing left to right, not only frontally, but across the entire cortex. We usually try to enhance symmetry wherever it's diminished rather than just frontally, because the research over the last, I'd say, 6 years on EEG asymmetry shows that it's not just frontal asymmetry. For a lot of children, it's a posterior asymmetry too in EEG that's related to mood. And so I think we need to take a broader picture. We need to start with the frontal, since that's where the research is. But I think that you'll find that it's a much broader picture with time.
Right. So why do you think that beginning with heart rate variability increases access to successful asymmetry training or reduction in asymmetry?
Because the ascending, if you stimulate the ascending vagal pathway on the left side, that tends to increase activity in the left hemisphere and increases dopamine output. And so I have a lot of articles, that I presented at ISNR on that. And at the same time, if you increase activity in the ascending right vagal pathway, it tends to overactivate the right hemisphere and create reduce dopamine and create more avoidance behavior. And so there's a good strong literature on that. And there's a couple of great articles. I don't know if I've ever sent them to you, but really some good stuff on that. So to me, for a long time, I've been watching how the asymmetry research has been going in EEG, and then looking at the vagal theory research, asymmetry research, where they're looking at, as you know, Jack, you can put electrical signals into the left versus the right ascending vagal pathways and produce approach and avoidance behaviors. And in fact, for depression, which is non-responsive to medication, a lot of times they'll put in vagal stimulators, or actually surgically put them in, and that's been done a fair amount. So to me, it's far less intrusive to teach people to control their ascending vagal pathway and encourage the brain to change at the same time. And for some of us, we actually do asymmetry training at the same time we give people feedback on HRV. Some people do that more than others. So I think that varies quite a bit. We also find that
other than a stimulation, as you're describing, I don't know how on earth a person could intentionally control right versus left vagal afference. That's really unclear to me.
Well, by doing with the heart rate variability, it tends, as the coherence goes up, the vagal input improves, the ascending vagal improves on the left side, which enhances EEG asymmetry. So that's the proposed mechanism that some of the researchers that I've been reading.
Well, there are different terminals of vagus on the heart that are left and right vagally controlled, and so the sinoatrial node is more left vagal, and the AV node is more under control of right vagus. But I don't see how that could be parsed out through any kind of biofeedback.
Well, let me send you the paper, and you can look at it.
Okay.
I got a couple of papers on that promote that idea, and I think you find them very interesting. So if we have ascending left and right vagal pathways, and we can stimulate them through brainwave training, we're going to alter heart rate variability. And in fact, if you do asymmetry training, you just monitor heart rate variability, you typically see improvements in heart rate variability. I mean, at the clinical level. What we really need to do is demonstrate it in a research setting, with a controlled group.
Yeah.
But it seems pretty obvious when you do it year after year, client after client, but we can't prove it yet.
Jack, one of the things I did years ago, and I presented it at the Southeast Biofeedback Conference, was I had somebody hooked up to HRV and was doing a traditional sort of neurofeedback 2-channel training. And I asked that person beforehand to tell me what made them stressed out, upset, anxious, and what made them feel calm and relaxed and compassion. So work was the stressor, the dog was the compassion. I said, think about work, and you would watch her coherence drop. Think about your dog, the coherence goes up. Think about work, it drops again. I went that back and forth 2 or 3 times. Then I did the same thing with her when we were training. And you could see with coherence, when it's good and someone's calm, what I was finding is the brain waves for coherence were integrating. In other words, your alpha's integrating. There wasn't any evidence of sadness or depression, whatever. And there was no evidence of the beta being too high, so you had more anxiety. So they work well together when you're looking at it as 2 separate systems. But when you look at it from that standpoint of somebody being able to talk about what makes them relaxed or not, and then watch it in their brainwaves, it's really quite interesting.
All right. Have we got other questions from audience?
Let's see.
Yeah, I have a quickie. Part of my standard pattern when I'm administering HRV training, I'll say, yeah, and this is good for students who do better on stressful tests. I want you to upgrade my pattern. Athletes win more games, performing artists do better on stage, and employees won't want to strangle their boss, plus reduces hypertension.
Yeah.
Can you improve on that?
I see. Well, with respect to HRV and the intended benefit, I mean, you might even try to make the case that lowering blood pressure at physiological level. I mean, there are data that healthcare outcomes are improved or should be improved, and so you might even just talk about general, not just emotional well-being, but heart health in terms of responsiveness, resilience to stress, has these downstream consequences of a healthier heart and healthier physiology. So that might be a selling point on its own.
Thank you.
All right.
Any other questions? Comments? Doesn't have to be a question.
Oh, hi, Dr. Suter. This is Yvette Lample here in Dallas, Texas. How are you?
I'm good, Yvette. You're doing well.
Yes, I'm doing well. Thank you for putting this training. I've recently just been doing some training with heart math and working with a lot of clients who have experienced trauma. And so I was really interested in hearing this talk today because I'm thinking of, on my line of work and working with children and family, and as they're getting back to school, one of the things I was collaborating and trying to introduce in our programs was some group interventions for the children as they going back, but introducing the heart rate variability in a group context. So I didn't know if you guys have had an experience with that. Doing it, a lot of times they're needing to co-regulate with their parent, and the parent is not doing very well either. But so I was, looking at the potential of doing this type of work, but doing it in group dynamics.
Well, if I may, I think it'd be really worth your while to just check out the Polyvagal Institute, because they do offer a lot of protocols that I think you would find applicable to the very scenarios that you're describing there. And they've got some experience and are beginning research on it, but more importantly, they have clinical protocols that I think would fit the bill for you.
Okay, thank you. That's helpful. Appreciate that.
All right, anything else?
Any other comments?
Yeah, that raises a very interesting question. Hi, everybody. It's Victor McGregor from upstate New York. You can hear me okay?
Yes, you're great,
Yeah.
Vic.
Go ahead.
The group affiliation raises an interesting point about when we're doing training top down, to what extent our unspoken values affect the
Uh-huh.
emotional regulation. For example, one's belief in this common emotion of what I call legitimate anger. In other words, if you see an injustice and you're outraged, is it okay? So the mindfulness kicks in as a value. Yes, I'm getting really mad because I'm seeing that our environment is pushed beyond its limits. So I'm trying to differentiate between, I don't want to get religious, but there is something called justified anger, right? So I allow myself to have this justified anger, and then the challenge is to channel it into a more homogeneous, homogeneous
Yeah.
balancing
Yeah.
of my,
Yeah.
okay,
Right.
you know
Right.
what
Right.
I'm
Right.
saying?
Right.
No. Okay,
Right.
thank
Right.
you.
Okay. Well, let me say, as you were speaking, and yes, of course, there are things that are justified, anger producing, anger provoking, and that's a good thing. And the whole, what I was thinking as you were speaking, that if you go back not too far in the past and just look at rational emotive behavior therapy, which
Mhm.
says that if you objectively evaluate using evidence and you monitor your emotions at the same time, what you're doing is you're giving yourself a chance to respond in a way that is healthy, but it's also effective. And so when things are wrong, when things are bad, I would only say that there is a way to adapt. And this idea of emotion regulation is broad enough that it will include positive and negative, as well as reduction in intensity, which enables access to this idea of rational thought or strategic planning, responding, managing. And whether it is a perceived injustice or on some level of moral violations, or whether it's a physical threat, which also produces, uncontrollable fires and tornadoes, things that are traumatically stressful.
Mhm.
They all sort of fit under this umbrella then of being able to formulate the best coping and adaptive strategy that you can. And I've
Mhm.
always liked to say that it is possible to be coherent. And by coherent, what I mean is resonance frequency. And in this model, this physiological state, it's possible to be that way on the battlefield of Armageddon. I mean,
Mhm. Mhm.
if you can manage your emotions and manage your rational thoughts at the same time, that's the best you can do. I mean, look, you're not
Mhm.
going to
Yeah.
stop. You're not going to stop or even change the world, but it does give you a chance to do the best that you can do
Mhm.
for coping, responding, and managing. That's a worthy goal.
Right. So I appreciate your efforts and all the other pioneers in this field in bringing to greater mindfulness this capacity to get to a point where it's okay to incubate and store stuff away in the back of the brain that I'll come back to later once
Yes.
my
Yes. Yeah.
anger is under better control. I'll be able
Right.
to then progress and look at the long haul in order to keep in mind the big picture here.
Well, sure. I mean, a part of that then would be formulating your own goals and your own
Mhm.
values. I mean, you're in it. You can't take yourself out of the equation. I don't think you want to be just sort of
Right.
abstractly pursuing some sort of goal or happiness or something like that. There has to be
Right.
some element that has to do with what your values and your constructs are and what your goals
Mhm.
are, and then you can map out a way to achieve that. So don't forget to put yourself in there as far as what outcomes
That-
you want,
right.
you would
That,
seek.
that's right. I'm mindful of my narcissism, but at the same time, we've got to healthy regulation. Appreciate everything. Thank you.
Yeah,
Bye-bye.
okay, great.
All right, we're at the top of the hour, aren't we, Rob? Not hearing from Rob.
Yeah, I was muted. Yes, we are. So, Jack, thank you so much. Great presentation. Folks will probably get this posted sometime next week. And everybody have a great weekend. And we'll see you all on Monday night.
All right, take care, everybody. Bye-bye.
Thanks, Jack. Bye-bye.
Hi, great presentation. Thank you.
Bye.
Thank you.
Thanks.